Assalamualaikum warahmatullahi wabarakatuh. To everyone who attending this first CME in 2024 under the Department of Faculty of Community Medicine. The CME will be start a little bit late, around in 10 minutes time. Okay, thank you. all the phones should be silent. Okay. Okay, Assalamualaikum, and ladies and gentlemen, we will begin our first CME 2024 around in physical session that already been held in community lab level 4 of UPM. Today we will there is Dr. Professor Liza and Dr. Anissa around here, and all the beloved MPH, the RPG students that will be listened physically, and with all the beloved audience in online sessions. Okay, we have two speakers for today. First topic is from Dr. Syahirah Ghazali, who currently doing her attachment at PKD Petaling. She will be talking about Unveiling disaster response, lessons from Elmina's plane crash. And second speaker is from Dr. Muhammad Akram bin Abdul Kadir. He doing his attachment at PKD Hulu Langat. He will talking about TB outbreak at Beranang Immigration Detention Center. So, without further ado, we'll be giving first topic to Dr. Muhammad Akram first.
Presentation. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. To my beloved supervisor, Dr. Professor Liza, my honored lecturer, Dr. Anissa, my colleagues, and my fellow friends. My name is Muhammad Akram bin Abdul Kadir. I am a third year DRPH student in UPM. Today, I would like to present to you my topic of CME entitled Outbreak at Beranang Immigration, TB outbreak at Beranang Immigration Detention Center. Okay, I will share my experience during my attachment in District Health Office of Hulu Langat. I bet you all know where is the PKD. It's in the Kajang bus station. Nearby. Okay, fit to do. All right, as an introduction, this will be our agenda today. My outline presentation, like present you introduction, incidence of tuberculosis in Malaysia, then the screening of it, the depot cluster, then I will explain to you our investigation results and lessons learned. Okay, to begin our CME. First, we received an SMS alert. I bet you have experienced, those have been in PKD, you always receive SMS alert or deliver this SMS alerts to your supervisor, to your MOH, to the JKNS, right? Okay, on 2nd June 2023 in Malay, okay, we thought it was a cluster TB, in Depot Beranang, basically. So initially we named it cluster depot, okay, because there was few cases, about 7 cases. It begin actually when few cases has been notified to Hospital Kajang, when being notified to KD Ulangan, right? But when we further investigate or PPKP, it was actually 7 cases, right? The first case was actually in January, in 20th January, and finally the last case that was identified, notified to us was 20th of May. Okay. In total, at that time, in May, the total cases was 7 cases involving 2 from Block B and 5 from Block D. Okay, about the incidence of TB in Malaysia. How is the TB incidence in Malaysia? Well, globally, it is 134 over 100,000 population. That's the TB incidence in the general population. In Malaysia, as you can see in this graph, it's quite small. From 2000, 2022 actually, the incidence has been increasing with a dip during the COVID pandemic era, and then been increasing back to the current year. Okay, this is the TB cases according to the notification rate, whereas the TB mortality rate basically it has been. The mortality rate has been basically also increased. Okay, how about TB in prisons? As you guys can always keep in mind that prisons, there are always people overcrowded the area. People are really bustling inside the cells. Right, TB incidents globally is basically from research paper from Coates et al. 2021. The TB incidents in prisons, basically this was in the US. It was actually 10 times higher than the general population. About the TB incidents in prisoners, okay, that was in Southeast Asia. It was about 1,500 cases per 100,000 population years, all right? Okay, but in Malaysia, according to a research paper published in 2019, he did multi-center cross-sectional retrospective study of TB incidents in Malaysia, involving 4 states in Malaysia. There was 11 prisons. The incidence was 440 per 100,000 population years. Okay. Okay, about a bit of background of TB. I think you always during your medical schools, the transmission is droplet infection, and then people will, because those infected will get primary tuberculosis. Okay, then they go either spontaneous healing or goes to latent tuberculosis, where mostly the incubation period can last up to 2 years actually. Okay. Who are the high risk groups for TB? Basically, those close contact with TB, those immunocompromised, substance abusers or smokers, or people living in crowded conditions. Yeah? And you can always keep in mind that those living in detention centers, if you have been once there, people are really bustling and overcrowded. Okay, a bit of background of Branang Immigration Center. It was actually, the name is Depot Immigration Sementara Millennium. Why is it Sementara? Well, during 2021, during the COVID-19 pandemic, Branang Immigration Center, Detention Center was established to put all the illegal immigrants to give vaccination for COVID-19. And it was actually intentionally to be a temporary detention center, but until now it's still present. Okay, basically, and then what do you call it? I think I don't have to explain more. Okay. Basically, in this detention center, there's all walks of life. There's children, those in the school age, 8 years, 6 years, up to elderly persons. Yeah. If you've been there during our screening, you feel kind of sorry about those little children. Okay. So what are these standardized? What is the standardized management of TB needs? Basically, those in TB, we as healthcare workers in the health districts, we need to kind of improve patient outcomes. We need to assist the monitoring of the patients and prevent emergence of MDR-TB. MDR-TB is multi-drug resistance TB. Okay, why? Because because of the challenges of TB treatment. Next, what are the issues of TB management in Malaysia? This is according to TBCO. TBCO is a program in Selangor called TB Case Officers, where they action mobile. These are medical officers in which they are mobile. They search for TB patients and bring them to KKs for treatment, or manage the social economic issues actually. Okay, so those issues include delayed presentation, inaccurate presentation, inappropriate empirical treatment in Malaysia, and high default rates, especially among immigrants and TB in children. Now, a question to ponder you all. Maybe you can search. What is the difference between an outbreak or a cluster? I think you've any takes? No? Yes, no? You've learned in the epic, yeah? What's the difference between an outbreak or a cluster? Never mind, I'll show the answer. I'll suggest some answers to you afterwards. Okay, to continue. Okay, as screen in case in any outbreak, we need to establish a case definition. Case definition of TB according to the case definitions 2017. Basically, bacteriologically confirmed tuberculosis or clinically diagnosed tuberculosis, right? Those are bacteriologically confirmed either through smear, microscopic culture, or gene expert, MTB, or radio frequency assay. Or those clinically diagnosed tuberculosis, those who do not fulfill the bacteriological confirmation for during lab, but due to radiologic evidences of TB, they can start TB treatment. Those due to, depending on the clinical judgments of medical officers. Anyhow, those diagnosed or those who are confirmed with or diagnosed with TB, they need to be notified to the PKD within 7 days. Okay. Screen of contacts in the TB Branang Immigration Center. Actually, after we enter the we enter in the TB Branang Immigration Center, there was actually 218 contacts from the index cases. I mean, the screening in depot in detention centers is a bit different from what we actually do in clinic kesihatan or health clinics. Why? Due to basically they are in detention centers, so their mobilization is quite a challenge. So what we first do is we assess their clinical symptoms and we do tuberculin tests. And tuberculin tests, the cutoff points, actually those immunocompromised is 5 millimeter, okay, in duration. Those not immunocompromised, we take it as 10 millimeters, right? Okay, if they are suggestive of TB positive, we ask them for sputum FB, and do a mobile chest X-ray. Okay, during our assessment, actually, there was those positive for AFB. We screen them. We actually assess them to do mobile chest X-ray in the detention center itself, and then those positive for chest X-ray, showing evidence of TB, are referred to the health clinics or hospitals. Okay, the first case definition of TB in the detention center of Semenyih. Any individual who has confirmed TB infection with EPID link with index case in January 14th, 2022 in Block B, and in 16th March 2022 in Block D. Basically, these are two initial cases in TB Semenyih, in Semenyih Detention Center. Okay. This is the outline of the TB. Sorry, this is a mistake. This is Branang Immigration Center. Then we have Block A, B, C, D up to H. But in this in this outbreak, we focus on Block B, D, and F. Other blocks are basically those for health clinics or other offices, right? Or kitchens. This is a schematic diagram of TB Brana Immigration Center. Yeah, this is during our assessment or the first screening where we do tuberculosis skin tests and symptomatic screening by medical officers. The detainees are those in green. Okay. So the chronology of Debu cluster. Initially, it began in January 2022 when the index cases was Mr. MM in Block B and Block D, Mr. MH. We screened initially in a month later for about around 170 contacts, but no cases was identified. Further on, until June to October 2022, we actually identified 6 cases. But then afterwards, in June 2023, we did another screening. We detected 7 cases from Block B and D. And finally, in July 14th, we did contact screening for 73 contacts in Block F, but no cases was identified. Adding on all the cases that was notified or we detected, there was a total of 18 cases identified for TB from 2022 to 2023. Okay, this is our investigation methods. We did risk assessment and case investigation, which actually began in May 2023. We did active case detection, mobile chest X-ray, and notified and take the samples from the cases and send them to the labs. Okay, getting the results. This is the result of the 18 cases in Depot Brana. Okay, the age basically is actually from 70 to 62. Okay, of the 18 of them, all of them were men. Most of them from Myanmar, one from Bangladesh, one from Somalia, and most of them were PTB smear positive. Okay, regarding the contact screening, we screened 218 in 2023. Okay, all of them were men. Okay, symptoms, about 1/3 of them have symptoms, about 43. Okay. This is the epic curve where is the linear trend line from 2022 to 2023. Right? As you can see, the trend is increasing inside the depot. Okay. Afterwards, we did cases investigation for each of the cases from case 1 to case 18. I'm not going to present all of them basically. But, basically the history are basically the same. They are basically they are captured from anywhere during their workplace at schools or in towns or in the streets. They're captured and then sent to detention centers around Malaysia, and then such as in Terengganu, in Ajil, and then deported to Branang, transferred to Branang, or be captured in KLIA Sepang, then transferred to Branang. Basically, the history is all the same. About the index cases, these are the 2 index cases. How did they get TB? Well, probably from the original country, most probably from Myanmar or from Rohingya. Okay. Okay, we skip. This is basically the lab investigation summary from Block B and D. Okay. We did basically the tuberculin tests and chest X-ray. Okay, we did not do any IGRA or gene expert due to costs. Okay, why you might wonder why only 136 of them are being tested for chest X-ray? Well, basically due to budget because the cost to screen 130 of them was about 10,000 mobile chest X-ray. We need to bring equipment to the depot, right? Okay, in summary, okay, basically, the index cases it began in for 2023. It began in February with 2022 with two initial cases from Block B and D. Okay, but in total in 2022 from screening there were 8 cases, while in 2023 was additional 10 cases. Finally, all of the depot cluster, there was 18 cases of TB. How about the current from current date? Well, actually, after the last screening from the report in July 2023, we did another screening in November. Okay, from that screening, there was actually an additional of 3 cases from block B, if I'm mistaken. Issues identified inside these immigration detention centers. Well, we have screening. There's a lack of health services inside the detention center itself, and the infrastructure themselves, where they are inadequately equipped for isolation of the detention detainees. All right, as a conclusion, okay, in the index cases, like I said, they could acquire the TB from the origin countries. Okay, and disease propagation basically due to close interaction among detainees, the lack of infection prevention control, and the inefficient infrastructure facilities to detain or to prevent the spread. Okay. Recommendations include pre-placement assessment, which is we need to screen those immigrants or detainees before they've been transported back from other detention centers to Branang. Okay, we need to strengthen the health services, in which we need to increase the medical officer presence, increase the frequency of screening, and lastly, we need to increase budget for infrastructure improvement, where we need to build isolation centers or isolation rooms to restrain all positive TB cases to prevent any further spread of TB inside the detention centers. So again, what is the difference between outbreak and a cluster? Any idea? Ada jawapan tu? What do you understand? What is the cluster? What is an outbreak? The student and their page is near. Easy. Okay. Abang Easy. Abang Fanilia. Abang Ikhwan. Bila kita nak panggil tu cluster, bila kita nak panggil tu outbreak. Sini. Request.
Dalam konteks epic, kalau kita tengok outbreak ni dia hari kepada pandemic, outbreak. In which outbreak ni kalau kita tengok case tu melebihi dari more than the baseline incident dia. Okay? It depends on the disease lah. Sometimes kalau contoh measles, we consider one case as an outbreak, for example. Tapi in case of poisoning, we take it more than 5 cases, for example, we consider it as an outbreak. Okay. Cluster pula, cluster ni is a term that is quite, I don't know, dalam epic kita kalau perasan cluster ni kita tak discuss well the definition. Tapi dalam guideline Malaysia company dalam COVID semua banyak digunakan pakai the term cluster, in which ditulis kat depan tu cluster ni it represent an outbreak, tapi that particular population is sharing the same exposure lah. For example, they are mainly dalam this case getting the exposure from the Koreans, for example, from one similar source.
You can find there is an epic link. Oh, there is a cluster. But basically, the recent guideline from KKM. Thank you, Iqbal.
Maybe Akram can explain further on the differences between cluster and
Okay, the difference between cluster and outbreak. Just like my answer would be almost similar to Ikhwana. Basically, when there's we still do not find an epic link between the case. Let's say there's a case of let me say not TB lah, a cluster of say HFMD ke, or pertussis ke. Okay, inside one classroom, inside a school, basically one classroom, and then another case of pertussis inside classroom B. Okay, there's two cases, but we still have not established the epidemiology link between those two. Okay, we still consider it as a cluster. Okay, but when we further investigate, we take the history. Okay, then we can connect dia punya epic link where the source or the disease propagation is from a single source, then we can call it an outbreak. Okay. Sebagai contohnya dalam case TB dekat Depo Beranang ni, the common sources was actually from the first two initial cases from Block B and D, and basically due to their mixing and not segregate and poor hygiene status, dia punya disease spread tu tak dikawal dengan baik. Okay, then the disease always spread, even though that we screen them, we do screening several times, and from that screening we fail to detect any new cases. But after 2 or 3 months, then a case appears. Okay, basically it is due to the long incubation period of TB, basically, but due to their mixing antara satu sama lain, the disease sampai sekarang from 2022 until now it's still present. I think like I said previously, there was we detect an additional 3 cases from Block B, and Block F ada satu case. The shared common exposure. Okay, I think this would be the end of my presentation. Any question? Thank you very much.
Okay, we open for around 10 to 15 minutes question Q&A. Already a lot of people in physically want to ask directly to Mr. Akram, Dr. Akram. Shall I begin with to the right, my right hand first, okay? Can you be a bit loud because you have online sessions audience? You can come in front.
Assalamualaikum. I'm Irfan, MH student. So I'm just wondering, did you experience any language barrier when you went there? And then how bad was it? And do you think that that could be the reason why it is so difficult for you or for us as I think the major stakeholders to give health education comprehensively to this pocket of population from different backgrounds and language? Thank you.
Thank you, Irfan, for that question. Precisely due to basically their foreigners, most of them from Rohingya, some are from Myanmar, Somalia. But to note you that these detainees have been in Malaysia basically for a long period of time. Some have been in for 10 years, 5 years, 2 years before they've been detained. They have actually worked in Malaysia for long periods of time. So some of them are quite good in Malay, but some of them, okay, we need to ask some of those being basically fluent in Malay to translate our questions to the detainees. Okay. Kalau suara kuat, tak ke depan boleh lah. Orang lain tak dengar nanti. Boleh perkenalkan diri dan soalan.
Assalamualaikum, my name is Jihan, MPH student. I just wonder, in this outbreak situation, is there any environmental investigations done? And if there is, what was the finding? And secondly, if it was not done, what's the reason? And for those who are well versed with TB, we know that in outbreak we are justified to investigate on a molecular part, meaning we can investigate DNA genotyping from National Public Health Laboratory. So was it done? And if not, is there any reason? And what was the limitations? Thank you.
Okay, thank you, Jihan, for that question. To answer, I just remember the previous one. Okay, for the TB genotyping, okay, I think just for last week, from our investigation we did few months back, basically we did genotyping when we sent the samples to MKK, and basically the genotypes basically are the same from a common source where the genotypes are basically the same. Okay. So what was it? Okay, the environment assessment, risk assessment. Okay, in my previous slides, I think I didn't mention here. Before we entered, we did screening to all detainees in Depo Branam. Some of the DPPKPs initially went there to do a risk assessment or environmental health survey to that detention center. Okay, as you can see that this detention center was initially a temporary detention center for COVID. Okay, so they did not basically all of those COVID positive are kept inside one block. Let's say block B. Okay, and then after the COVID-19 era subsided, and then this TB outbreak comes. Okay, basically there are no isolation rooms to place those positive with TB, or if that is so, let's say we in the previous screening in November 2023, where we detected 3 cases. Okay, these 3 cases can be isolated to a single block. Let's say a block. There's plenty of blocks I've mentioned earlier. Let's say we detain them in block E, for example. But as you know that TB has a long incubation period, up to 2 years. So even if we isolate some of them, those who are not being isolated yet may have been spreading TB among themselves. Then this TB outbreak or TB infection will never subside, unless there is actually a budget to do infrastructure changes, so that we can basically isolate those positive or likely positive in a single place, segregate from those healthy, to actually prevent or to mitigate this outbreak from spread. Any further question? Yes, Ahmad.
One question from
What?
Assalamualaikum, I'm Ahmad Hamdi, MPH student. Thank you, Akram, for the very informative presentation. My question, okay, I believe TST or tuberculosis skin tests have been done among contacts, and definitely there are some young positive, right? So how do you go about with this population?
Okay. This is the summary for context. Here. And you got from all those contacts in Depo Beranang, about half of them are basically tuberculin skin test positive. Memang dia punya duration yang membesar lah, basically. So that's why those highly indicated, kita buat mobile chest X-ray, about 130 of those most likely to be positive. And from those 130 mobile chest X-ray, 27 of them have basically positive changes or for TB infection. Ada cavitation, ada dia punya lungs dia memang consolidated. Then when they will refer them to health clinics and hospitals for further treatment. Again, isolation of these patients, these detainees, between others, are quite difficult in detention centers. Yes.
Some of them is symptomatic. Your close contact, some of them are symptomatic, some of them are asymptomatic, right?
True.
Do you think the word screening is proper?
Word screening is proper.
Yes. You said you conduct a TB screening for the close contact.
Basically, all of the detainees in Depo Beranang are close contacts.
Yes.
So basically, we screen all of them.
You screen all of them.
Yes.
Is it the proper words of choice for screening?
In Malay,
If we go back to epidemic, if we go back to our epi punya subject, screening has its own definition.
meaning.
We have to be careful sebab bila kita patah balik PKD, what happened actually? The word screening is generally, it's not generally. It has been used so many often that it has lost its purpose now. Sometimes, and some of the slide also you said that health screening. What does it mean, health screening? Is it health medical checkup?
We
Kan? That's what I meant lah.
Okay.
So if we go back to EPID, for example, kan, is a presumptive identification, kan? Screening ni from an asymptomatic population.
True.
So in your population in dalam close contact, for example,
True.
it consists of an asymptomatic and symptomatic population.
True.
So it doesn't suit the word screening actually. That's my point lah. So actually we have to be careful with the word screening, early detection and early diagnosis, because those three terms has different meaning. Okay. So the words that is more suitable in this case is early detection.
Early detection is it? Thank you very much. Ikhwan for the input. Thank you very much, Ikhwan, for the input. But again, those Rohingyas in detention centers, basically they do not manifest any symptoms, or basically they are asymptomatic. That's why we need to screen all of them, because not all of them basically they convey what do they have due to the language barriers. So that's why we need to screen them. We need to ask them, do they have any symptoms or cough and so on and so forth.
What I mean is that early detection, under the umbrella of early detection, it can be divided into screening and early diagnosis.
Alright.
So among asymptomatic population, we call the process as
Early screening.
but among those population with symptoms, we call it early diagnosis. So all both of these comes under the term early detection. That's the proper terminology usage lah, if we want to discuss. Sebab bila you kata health screening, actually what comes to our mind, it's supposed to be that the close contact is asynchronous. But looking at the background of your story, it's actually is not asymptomatic population alone. It also comes together with symptomatic
Yes, some perhaps have.
so you have to be careful with the choices of terminology lah. That's what it meant. Sebab bila kita patah balik PKD, it goes back to the apa orang kata dia punya cara lama.
So we need to change that. So,
Sebab
we need
kita
to
dah
use
masuk ke uni, kita dah belajar the proper way. Nanti patah balik, improper way balik.
okay, I'll keep that in mind. Thank you very much. Other questions? No?
Bukan aku question susah. Just nak clarification. If
Thank you, guys. No,
this detention center, is it
Tak ada. Tak ada. Tak ada bateri.
dalam
okay. Thank you, boss. This detention center, it is under which ministry?
immigration is under which ministry?
KDN.
Right. So who give you budget to do all this?
Okay, basically the budget for screening from
The budget for
who do the screening.
and active case detection and whatnot.
We do the screening is our budget from PKD. Using PKD's budget. It's not from KDN. Tanya. Macam mana? Depo ada visiting doctors. Tapi kekerapannya
You mentioned the issue of having to do portable X-rays and so on. So those are budgeted under PKD. It is not under KDN.
No.
No. Okay, so that's the limitation.
That's one of the
Yeah,
limitations.
one of the limitations that is faced by Ministry of Health. Yeah, because as we know, the issue of illegal immigrants, the main issue is because our border is penetrable by these illegal immigrants. Yeah? So when we do not take care of our borders carefully, this is among other things that will happen. One is globalization of diseases. Yeah, that is one. Another one is socio-cultural issues and whatnot. Yeah, so when we talk about the social determinants of health, this is actually part of what is going on. Yeah, okay, itu saja.
Thank you very much, Professor.
Congrats, Akram.
Thank you very much, Professor Liza. Okay, so,
Thank you very much, Dr. Akram, for the sharing experience. For me, it's quite very worth to know how it feels to go through the detentions. And actually, it's, when we want to, for me, it's when you know the theory how we want to treat TB, but how we want to apply to the real world, especially in detentions. We have to play with multiple stakeholders. We have to convince a lot of people. So it's a bit tricky, and I think PKD Hululan are trying their best to solve the problems. But we learn from what we learn from them. For the second presentation, we would like to listen to the sharing experience of one of the Dr. Syahirah when she attended the tragic plane crash that's happened last year. So without further ado, I invite Dr. Syahirah.
Thank you, Lisa, Dr. Lisa. Assalamualaikum warahmatullahi wabarakatuh, and a very good evening to Prof. Rose, Dr. Anissa, and my beloved supervisor, Prof. Halimatul Sadia, who can't attend the session online physically today, but she's with us online. All right, so my name is Syahirah, and I'm currently doing my residency attachment in Pekerjaan Kesihatan Daerah Petaling. And this is the topic of my presentations today is Unveiling Disaster Response, a lesson from Elmina crash. Basically, it is just a sharing session of me being part of a rapid assessment team representing Pejabat Kesihatan Daerah Petaling, right? So this is the flow of my presentation, introduction to disaster, Elmina plane crash, what happened on that day, what were the response from Pejabat Kesihatan Daerah Petaling, other agencies' involvement, limitation, challenges, and way forward. So a bit of recap on the definition of disaster. A disaster can be defined as any occurrence that causes damage, ecological disruption, loss of human life, deterioration of health and health services on a scale sufficient to warrant an extraordinary response from outside the affected community or area. All right, so if you can see, there was types of disasters like what we've learned previously. We have natural disasters and also non-man disasters, and air crash belong to the technological disasters. So the NATMA also categorize disasters into different categories, and as you can see, air crash accident also is part of the man-made disasters. So basically, principles of disaster management is to minimize the casualties, prevent further casualties, rescue and victims, first aid, evacuate, medical care and reconstruction. And this is the disaster management cycle. Like what we've learned previously, we have 4 phases: preparedness, response, recovery, and also mitigation. Okay. So I won't go into details on all these phases of disaster management, but the presentations today, the gist of the presentation today will be focusing on response. So response basically involves search and rescue, clearing debris, feeding and sheltering victims and responders, and the aim is to protect and save lives and livelihood, society, and also property. So types of disaster victims, we have primary or impact victims, which are those who are directly involved in the disaster. And secondly, we have context victims who do not experience a disaster directly, but are often exposed to death, destruction, and social-cultural disorganization due to the disaster. And these, the context victims can be the family members as well. So the entry victims are people who enter the impact area during the post-disaster crisis period and may witness death and destruction. And during the event, we consider the RAT team as the one of the entry victims. Okay, and then also we have peripheral victims, which are those who have strong ties to the impacted areas, they suffer distress and uncertainty over the safety and well-being of family and friends. Okay, now let's go to the Elmina plane crash and we see what happened on that day. So for those who are not familiar with Elmina, Elmina is actually located in Shah Alam and is formerly known as Elmina Estate, which is owned by the Ghazali Berhad, now known as Sandabi, and estimated population is about 45,000. And it's a very nice area. And okay, as you can see, this is where the airplane crashed, the plane crashed. And this is the Subang Airport, which is about 7 kilometers, 6-7 kilometers from the crash site to the Subang Airport. And as you can see, there are also other residential area around here. We have Subang Bestari, which is quite highly populated residency. We have Denai Alam here, in which my house is here in Denai Alam. And then we have also Sungai Buloh here and Kota Damansara. And one of the bomber told me that if only the plane crashed over here, it would be very major disaster because it will hit all the schools and all the residency area here. So luckily the plane crashed just around at the Elmina Park. Okay. Right. So coincidentally, 46 years ago, we had the same plane crash, which involved the Japan Airlines crash. crashed at 6 kilometers from Subang Airport, which formerly known as a rubber plantation estate and now also known as Elmina. Right, and then the crash killed about 34 of the 79 people, 69 passengers and 10 crew members. Okay. So, synopsis of the event, the date of incident is 17 August 2023, about on Thursday. It happened on 2:51 p.m. and locations at Guthrie Highway. So at this time, actually, the school children were like coming back from school. And in fact, my daughter also bypassed this road at around 2 p.m. That day. Right, so it can happen to anybody living in this area, right? And this is like from the, I think the video from the dash cam. Okay, all right. So just a bit of synopsis of the event. At about 2:08, a Hawker Beechcraft Model 390 operated by the Jet Bowlers near Berhad departed Langkawi International Airport to Subang Airport. And about 2:49, the craft impacted the ground while maneuvering for landing at the Subang Airport. And the airplane was destroyed, and the 8 occupants and 2 ground bystanders were fatally injured. Okay, this is actually the preliminary report issued by the Ministry of Transport Malaysia, which was issued in September 2023, about 1 month after the incident. All right, so this is actually what happened. This is from the prelim report as well. At 2:08, the craft departed Langkawi Airport with 8 persons. At 2:47, the crew and the craft contacted Subang Airport. Tower controller requesting to land. 2:48, the craft was cleared to land on runway 15. 2:48, also the craft acknowledged the clearance. And about 2:49, the airplane began to right turn. And at 2:49 also, that was the last recorded data transmission from the accident flight. Okay, so there were no survivors in this catastrophic accident, as everyone I think was well informed. There were there were 6 passengers, 2 crew, and also 2 bystanders. One is a foot panda rider, and another one is a Grab driver. Right. Right. So basically, this is runway 15, in which there's the plane is supposed to land, but it turned right. Okay, so the final report, Elmina air crash will be out by August next year, as they have their own KPI in which they have to produce a report 1 year after the incident. So what had been issued by MOT was the prelim report. Okay. So, okay, what happened? This is the disaster flow management at PKD Petaling. The commander is our MOH, and the timbalan will be the PKD2 ataupun pegawai EPIC. And also we have ada subunit operasi perancangan logistik keuangan dan sumber manusia. And the ROT team is under the operasi. So this is the flow chart from the PKD Petaling as well. This is not specifically for airplane crash, as we do not have that chart yet. So this is general flow, but it applied to most of the flight disaster. Okay. So what happened on that day is the plane crashed at 2:51 p.m. and then at 3:05, the H-Star team was first to arrive at the scenes, and they received the information from the public, from the rumor surveillance, and one ambulance went there, and on the way, they confirmed, they verified the rumor surveillance. So it showed that they have quite a rapid response. Once they received the rumor surveillance, they straight away sent one team, which is the team 1, the ED team, which was the emergency physician, 2 medical officers, and 3 employees. And once they verified and confirmed the disaster, the plane crash, then another team, they sent another team which consisted of the forensic team. All right, and then at 3:20, the hospital Sungai Buloh team arrived, and about 3:31, other ambulances arrived at the scene. Okay. Okay, unfortunately, we only got the information at about 4:10 p.m., a bit late. And then we received from the remote surveillance as well. So it took some time for us to verify the crash. So we need to call the bomber, and then we called the police to verify that. And once we verified that, then only we can send one RAT team to the crash site. So we arrived quite late, about 5:45, almost 2 hours after the incident. As you can know, at this time, there was a heavy traffic jam as well from PKD Petaling to this Elmina crash site. All right, and then at 6, RAT team identifying medical resources at the site. And then at 6:10, medical forensic entered the crash site once it was declared safe. 6:30, RAT team lies with the EP, emergency physician, HSTAR, to arrange for family members to gather at HSTAR. RAT inform family members to gather at EP HSTAR. So bear in mind, at this moment, in these crash scenes, there were family members as well. So the families were all shocked, and some of them were stupid, like they can't even talk, and they were like sitting in the same area with us. So after some discussion, we decided to transfer the family members to HSTAR, in which they can receive a proper psychological first aid assessment of psychological first aid, because it will be very traumatizing for them to stay in that crash scene area and watching, and hopefully there was some, hoping for some survivors from the crash site. Okay, and at 6:53, RAT team gathered information, SMS alert and laporan awal we sent to PKD and also to GKN. And at 8:30, press conference by Inspector General of the Royal Malaysia Police. And about 10 complete craft recorders sent to Biro Siasatan Kemalangan Udara. At 10:40, we had this discussion with the commander and also the medical forensic team, pathological and toxicological team, and which they update on all the biological tissues were transported to the medical forensic department, HSTAR, for further identification and post-mortem investigation. And then at about 11, RAT team update progress to PKD. About 10:30, search and recovery operation by medical forensic team discontinued for the day due to poor illumination at night time. And about 12:30 a.m., the RAT team then stand down. So basically, this is the chart for disaster management, the scene of incident according to zones. And we were at that time, we were in the yellow zones together with the forensic team. Okay, and the green zone were actually for the media. But once we arrived there, we were still, they didn't really zoning the area. So that's why we were like in the same area with the family members and everyone else. So this is the RAT team. We have 3 medical officers, 2 PPKP, and also 1 driver. Okay. So one of among the roles of RAT PKD Petaling was to identify available medical resources at the site, including number of staff, number of ambulances. There were no casualties at the moment, so our priority is to ensure the resources were available, and acknowledging the vulnerability of the family members, liaising with other agencies to get updated information at the scene, and updating and reporting the situation to PKD and also to JKNS. So this is some photos during the disaster event. We report to the commander once we arrived, and then we received a visit from the Yang di-Pertuan Agong, and also there were so many multiple agencies involvement at the crime scene, at the crash scenes. And we tried to identify medical resources available. Then we gathered information for SMS alert and laporan awal. Behind us is actually all the family members who were like shocked and grieving. And this is, I'm sure you've seen the photos in media social as well, but to be there and experience the traumatic event, being there, you can smell like the smoke coming, the burnt smell, and you can see the scattered limbs, like the hand, the food, like, and then it was, I think, such a memorable experience. Okay, a very tragic moment for them as well. Right. And then this is forensic team searching the area for the crash. This one we updating the progress to PKD Petaling. We got our own temple, which is actually not for KKM. There's no specific temple for us. There's no specific tent, but the Jepam, they help us by provide this to us. Okay. This is the press conference at 8:30 p.m. Right. The next part is other agencies involvement. There were multiple agencies involvement. Kementerian Kesihatan Malaysia in total there were 17 staff, including the drivers. Jabatan Bomber about 42, Polis Diraja about 50. As you can see, there were Civil Aviation Authority Malaysia 9, Country Corridor S-Way 6, Police Bomber, and at that time, the Guthrie Corridor S-Way were the one who provided us food, with the food. Okay, so I think this is the last part of my presentation. Okay, the lesson learned, I would like to summarize in terms of the challenges, limitations, and also way forward. So I'll divide it into communication, coordination, dealing with grieving and family members, and also actually psychological support for the entry victims. So number one is communication. I think from our observation and from our experience, there was some sort of limited communication between agencies. I think that might occur in any other disasters, but specifically for airplane disaster because it is an unexpected event and no one actually is prepared for it. Right? So PKD Petaling received information only from human surveillance, which took some time and needs to verify it before activating the RAD team. So based on this, Collins 2016 stated that social media is now the most efficient method of delivering emergency response messages in a contemporary urban crisis scenario. It is true, but whatever it is, we need to verify the situation first. And moving forward, information on disasters should be conveyed in one disaster alerting channel to ensure the information can be communicated to all relevant authorities on time. So currently, what we have in PKD Petaling is we have this WhatsApp bencana. I think it applies to all PKDs as well. In this WhatsApp bencana, we have all those higher up authorities, including PKD, the bomber, the police. But however, during the incident, no information was conveyed through the WhatsApp bencana. So it was quite sad because we have that mechanism, but it's just that we don't apply it. Okay. So second one is coordination. There were some challenges in synchronizing the management between the medical and also the public health. In terms of the management, we have the ED team, the medical part, they came earlier, we do their own management, and then us, the Kesihatan Awam part, we do management, and at the end of the day, we do not report to any one person. Okay, so, once, when we try to gather the information, like the data, or we want to compile the data from the KA side, the medical side, we had some difficulties in finding the information from the medical side because we have to go through the higher up. But actually we are as one team. Yeah? So, and then coordination. Also there was duplication of ambulance services. In total there were 7 ambulances were there. there's no need of ambulance because there's no survival at that time. But because I think there's no coordination directly involved in this particular disaster. And going forward, need to assign one medical commander. It is written in, theoretically, it is written there, but on site, it was a bit, it was a bit messy. And then you have to unify the management reports from both medical and public health, and there's the exercise on disaster management. So one of the initiatives done by Jabatan Kesihatan Negeri Selangor under the surveillance unit is they tried to do this institutional memory for Elmina plane crash, right? And I had the opportunity to be part of the members for this institutional memory. We had this meeting last month online, and the second meeting was supposed to be today, this evening. Okay, so in this institutional memory team, we have one EP from HISTAR, one from Forensic HISTAR, one from Bahagian Perubatan, one PFA staff, and one staff involved directly, and indirectly in the event, and also Pasukan Kesihatan dari Sungai Import. So we will compile all those institutional memories, which include plane crash, tanah runtuh, and also flood. These three disasters will be compiled, and we aim to launch the book by December 2024. So it's like a coffee book for all these disasters management. Okay. Another one is dealing with short family members at the scenes. As you are well informed that all the family members were shocked at that time, and way forward, PFA should be tagged along in the next disaster event, as we do not have the experience to deal with these emotional situations between the family members. So if the PFA if the PFAs were there, so I think it will be more comfortable for the family members and also the staff as well. Okay, and then the last one is dealing with entry victims. As I mentioned earlier, entry victims mean those who enter the site during the incident, and this include the medical personnel as well. Maybe not for the forensic team because they had the experience before. This is not a new thing for them, but for us, it is quite traumatizing when you keep on have these visual memories and keep on repeating in your mind. Because you saw the pilot, how does it look like, and you see the pilot with that, situations, yeah. So they will no PFA offered to us, but we do try to seek those who need that, try to contact the PFA themselves. Okay. So this is the last slide. As a conclusion, effective communication and coordination, both between different agencies and within each responding organization, are paramount in managing the aftermath of a plane crash, and prioritizing psychological support for both victims' families and others involved is crucial for addressing the emotional toll of such a tragic event. So I think that's all. Thank you.
Thank you, Dr. Wan, for such unforgettable experience. So I would like to invite for Q&A sessions. Okay, please come forward and ask Dr. Wan Syahirah.
Assalamualaikum and good afternoon. Thank you, Dr. Wan Syahirah, for the interesting presentation. Very intriguing. My question is just to fill in some context on what happened during the event. For context, also, I also worked in PMA before as a health officer. So one thing, does PKD Petaling has a health office in Airport Subang? No, okay. And then I might missed it, but did the airport detected the plane maybe lost communication or had problems in the air earlier before the crash happened?
Yes, that was the last time. Like they did detect it, but nothing much can be done because that was like the last time at 3, I think about 2:48 like that.
Okay.
They turned right.
So it was quite sudden.
Yeah, it was quite
So
sudden.
no mayday before.
No mayday at all.
Right. So yeah. So yeah, in real world situation it might be different when compared to drills that being done. It's just want to ask whether if it's so it's within the 7 or 8 kilometers range where it's well within the kind of the range of your airport services to attend your FSRS and with the health at the airport, they will follow the FSRS. So whether if it's feasible, if we Airport Subang has a PMA unit, pintu masuk unit, or have point of entry unit in Airport Subang, since it and another plus is since it's an international airport, whether you need to perform your kind of IHR competencies and everything at the airport, or PKD Petaling just covers that. Yeah.
Okay, thank you for the question and suggestions. Yes, Subang Airport, Subang Airport is not actually under PKD Petaling. Subang Airport is specifically under PKKIA, but because of the distance, so that's why we go in at that time. But we're going to have some sort of discussion with the Subang Airport management as well to discuss on this thing. Okay, thank you.
Assalamualaikum, very good evening. Thank you, Dr. Wan, for very enlightening sharing of experience. I'm just wondering because we highlighted the challenge that communication between medical and public health, or specifically in this case MECC and the CPRC, very poor. It's 1 hour plus from they know that, then after that then we know. So my question is, I was thinking that it will be better if MECC was put under CPRC rather than under ED, because because I want get the feeling based on this experience and also previous personal experience, and maybe some of our friends say that we have very difficulties on getting information from MECC to us. That's I think everybody agrees, right? So and number 2 is that ambulance, they only MECC only caters for around the hospital, but farther away, public health is the one who handle the ambulance. So why? Is in after this event, is it better that MECC was put under CPRC or under public health in general rather than under ED specifically? I just want to share an opinion. Thank you.
Okay, thank you, Doctor, for the suggestions. I can't really comment on the MECC listing under, because I think that one is a bit difficult. But we do have some sort of discussion about this issue. I think it's been going on. Number 1 is about, I go for the first one, the medical and the public health fraternities. I'm not so sure about other disaster. I think they were more synchronized, such as if it's a flood disaster, because that is what being practiced, but not in airplane disaster. And then because why they have so many ambulances, because they receive information from KVAS as well, and from the public as well, and that's why the NGOs also come. So the 7 ambulances is not primarily from the KKM itself, but from the NGOs as well. What we have 4 ambulances from SEERS and 3 ambulances from Japan as well. Two from SERS. And then actually, based on that locality, this is not HTAR, it's supposed to be under Hospital Shah Alam ambulance. But somehow they activated the KVAS. So that's why HTAR comes through. But in terms of the other one, MSCC under the one, I think it makes a level up discussion.
Prof. Rose.
For the next
Anyone want
question.
to comment on that?
Good evening. I'm just curious about certain things regarding your regarding your recommendation tabletop exercise. Did your states or district have ever encountered any tabletop exercise with multi-agencies? And after the incident, did you raise up your concern about the risk communication through the WhatsApp, the defect in it, and what's the feedback? Thank you.
Okay, thank you very much. The tabletop exercise, yes, we do have that, but basically, we never have this airplane crash tabletop. Usually we have flood. We do have flood. We have radiation disaster as well. About the concerns, yes, we do have the meeting with the JKNS, the surveillance, like for the institutional memories one. So we raised up our concerns already. And that's why we have this institutional memory is also to discuss what are the steps going to take if similar incident occurred. So that's why the team members of the institutional memories consisted of EP from Histar and also Perubatan and KA Kesihatan Awam site and forensic and all those things lah. So we're gonna have this discussion every month on the last of Friday.
Kau ada dua, aku ada berapa?
Good evening. My question will be very short actually. Thank you for this presentation, very interesting. It's very unfortunate actually we have this event happen. But my question is just now, when this event happened, so there's a lot of things that we can question because one of the reasons is a communication barrier. We had a very bad communication barrier between all the agencies. And the one just now, actually the conclusion, one of the recommendation all came with the institutional memory, right? So this incident happened only in Selangor. Is there any other plans in the future? Because it could happen anywhere in the Malaysia, in other states. Any programs or any plans to do collaboration between all the agencies so we have a proper flow if events like this happen which involving the public health?
Okay, thank you very much for the excellent questions and opinions. For the time being, we only focus in Selangor. That is what the JKNS were doing, but I'm not so sure if other states are doing that as well. But I think the coffee book that we're going to produce will be used as the guidelines for the KKN and those multi-agencies involved. But as far as I know, now it's only happened in Selangor. I'm not so sure about the other states.
Ada.
Okay, we have one question, one from to Dr. Wan and one to Dr.
Okay, a question from audience, Dr. Adiba. The question is the time interval between the crash incidents, information verifications, and the first dispatch of RATT to the sea is somewhat long. Are there any strategies to improve for these problems?
Strategies to improve the problem. Number one is we need to have some. Okay, number one, we already have this WhatsApp bencana group, so we need to use that readily accessible platform. Or there were also other suggestions when we discussed to have this sort of e-notifikasi. It's like dengue notifikasi or things like that for disaster, in which those who can access to that we get the information earlier. Sort of e-notifikasi bencana. We do have it for flood, I think, but must be specified to every disaster. And then there were also delay at that time of response. Number one is because we received the information a bit late. Number two is because we have to verify. We have to contact two different agencies to verify the incident. And number three, because there was a traffic jam from PKD Petaling to the Elmina site. I hope I answered the question from Dr. Adiba.
It's for for Dr. Akram. Okay.
So to answer some questions from the Google Meet chat box. I think some of them has been answered previously. What is the cutoff point to end TB outbreak? Since the incubation period is long, it's 2 years. If there are no cases within 2 years, then we can end the outbreak. So it's a long, because they have a long incubation period. Okay. Next. Regarding chest X-ray to the detainees, I think I explained this, where we did chest X-ray to 136 of the detainees, mobile chest X-ray. Those with suggestive changes, about 27 of them, we referred them to health facilities for further treatment and investigation. Next question, how about staff, immigration staff? Did we screen them? Yes, we did screen them, but none of them were actually detected as positive. I think that's about it. Questions from the Google chat. Thank you. Thank you. Yang tak ada.
One question.
Congratulations to Dr. Syahirah. That is a very interesting presentation, and it is an invaluable experience to be able to be there during the event. Can you highlight what is the public health aspect of disaster management at that point?
Okay, thank you, Prof. Rose. I think mainly the public health aspect at that time of incident, we're mainly focusing on the surrounding as well, not only those who are involved in that area, but during that time, number one, there were no casualties from the victims, and there were no casualties from the outsiders as well. But our roles will become more prominent if the incident occurred around the neighborhood areas, around the schools, or the houses like the Kampung Melayu Subang, which is like few kilometers from the crash scenes. So, at that time of point, actually there were no specific point for public health area at that time during the RAT team, but we represented the only KKM team that was there at that time, because in addition to ED, but the ED went back earlier because because so we were there with the forensic team and we were not allowed to go home by the commander because they said you are representing the KKM. So that's why we were there and collecting information and updating our PKD and JTNS.
We have to understand, whenever disaster occurs, there are many stakeholders. In fact, in Malaysia, we have one body that look at disaster management, which is NADMA. So NADMA has their own flow chart, those who and whatever the actions that need to be taken. They do regular exercise, tabletop on different disasters. So we must understand as public health physicians, where do we sit? So those the RPH students, some of you have taken the public health aspect in disaster management. Not everyone took the class. Next time. So there's one subject on public health aspect in disaster management where we will emphasize on just your role as a public health physician. So in disaster management, you have prevention state, mitigation state, preparedness state, response state. Last kali apa, Ikwan? Recovery state. Ikwan publish a paper on disaster, kan? So under that subject, kan? Yeah. So for us in public health, most of our role are actually in the prevention, mitigation, preparedness. During response, not so much. So this is actually the response stage, kan? When impact occur, disaster occur, at response stage. Biasanya yang memainkan peranan yang paling besar in terms of health adalah the first aiders lah, the hospitals. So that is why I think they reach there first. So during response stage, public health component is actually to help in with the psychological first aid lah, to look at the and the area, make sure the areas are safe. If there is any gas leakage ke apa ke, environmental safety, occupational safety yang tu. Tapi dari segi the life saving exercise tu, it's not under us. Okay. And the last stage during recovery also public health play quite a big role in disaster management. So it is an invaluable experience to be there, and to experience it, and also to identify the challenges and barriers. So well done, congratulations again.
Thank you, Prof, for the closings of our reminder and how our public health works during response during disasters. And with that, in summarize, hope we can learn something from the presentations and sharing moments from today. That's all from me.
Okay, thank you to the presenters. As you can see from the presentations, there are things that you will learn in class which you cannot apply due to some limitations. However, it's not impossible. We hope that when you get out from here, you will be our agent of change. However small contribution that you can do, start somewhere. Okay, and change the situation which needs to be changed. Ekman pointed something, okay. Other things from the limitations that you have already heard, okay, you can always find a way to overcome the limitations. Okay, refreshments. We have refreshments here for you all. Please have some before you go back. Yeah. Okay. The next session is on 22nd March. By hopefully if there are no changes in the date, but we will update you all from time to time. by the OM, Occupational Medicine Unit. Okay. And hopefully everyone has signed their attendance form. Yeah? Okay, not saya kejar. Okay, thank you. And thank you to those who attended online also.